Welcome to Newborn Education, your trusted destination for practical pediatrics, neonatology, NICU Pearls, and evidence-based child health education. I'm Dr. Anand, and in this channel, we simplify complex pediatric concepts into clinically useful, easy to understand learning for medical students, residents, healthcare professionals, and parents. So whether you are preparing for exams, managing patients in NICU, or simply trying to understand your child better, you're in the right place.
Neonatal resuscitation is all about precision, muscle memory, and split-second decision-making. Well, the American Academy of Pediatrics and the American Heart Association just rolled out their latest science, and we're looking at some massive, workflow-altering updates to the 9th edition of the Neonatal Resuscitation Program, or NRP. They are fundamentally shifting some of the core actions we've been practicing for years. So we're going to break down exactly how your clinical workflow needs to adapt so you can provide the absolute best outcomes for these vulnerable new patients.
We're going to walk right through a delivery room resuscitation chronologically. On our agenda, 1. The updated resuscitation algorithm. 2. New cord management plans. 3. Initial steps in oxygen. 4. Revised ventilation parameters. And 5. Airway and intubation updates. Let's dive in.
Section 1. The updated resuscitation algorithm. We are starting the clock right at the very moment of birth. Take a look at this newly published algorithm. See that red bracket right at the top left? That's your explicit visual reminder for the golden minute. It's literally front and center now. The whole algorithm has been restructured to actually reflect the chronological reality of a delivery. It's not just a ladder of interventions anymore. It's a highly specific sequence of early actions that sets the stage for the entire resuscitation effort. So, what's actually changed here? Well, birth is now explicitly listed as action step number 1. Boom. Followed immediately by initiate cord management plan. But here is the real kicker for our muscle memory. They've officially removed routine suctioning from the standard warm, dry, stimulate sequence. Yeah! Unless that baby explicitly needs their airway cleared of obvious obstruction, you skip the suction. This is a massive move toward minimizing unnecessary interventions that could delay more critical steps or just cause the infant distress. Moving right along to Section 2, New Cord Management Plans. Let's see how this affects our timeline right at the delivery bed. And this brings us to a magic number, 60. Seriously, if you take away just one number from the early steps of this explainer, make it this one. 60 is your new extended baseline time, in seconds, for cord clamping. The transitional physiology science is telling us loud and clear that letting the newborn keep receiving placental blood flow during that first minute is just immensely beneficial for their cardiovascular stability. The guidelines now explicitly mandate that for most vigorous newborns, you defer clamping the umbilical cord for at least 60 seconds. Notice that phrasing, at least. For a long time, we hovered around that 30 to 60 second window, right? Well, the baseline has definitively shifted. If that infant doesn't need immediate life-saving resuscitation, your hands are completely off those clamps for a full minute. Now, what if early clamping is totally unavoidable or the baby just isn't perfectly vigorous? The 9th edition has our back here too. Intact cord milking, pushing blood from the placenta toward the baby before clamping, is now a reasonable alternative. But, and this is crucial, it's only for a specific group: term and late preterm infants between 35 and 42 weeks gestation. You must completely avoid cord milking for highly premature infants under 28 weeks. The rapid fluid shifts from milking are strongly linked to a higher risk of severe intraventricular hemorrhage in those fragile preemies. Just don't do it. All right, Section 3, Initial Steps and Oxygen. Moving further down the algorithm, we hit a big change in how patient we need to be. This is a massive philosophical shift. Just look at this comparison. Back in the 8th edition, we were checking the target oxygen saturation table at the 1-minute mark, looking for 60 to 65%. Well, the 9th edition totally deleted that 1-minute row. Our target expectations have been pushed back, and we are officially starting the clock at 2 minutes. Here's the new table. Starting at 2 minutes, we're aiming for a 65% to 70% saturation target. And why this matters is profound. It reflects a much more patient approach to natural oxygenation. Healthy babies take time to pink up. Going from fetal hemoglobin and fluid-filled lungs to breathing room air does not happen instantly. By starting the chart at 2 minutes, the guidelines are actively trying to stop us from prematurely dialing up supplemental oxygen, which we know causes oxidative stress and long-term damage, especially in the little ones.
Okay, Section 4, Revised Ventilation Parameters. Let's talk age-specific targets.
If a newborn's heart rate stays under 100, or they're apneic, and you need to start positive pressure ventilation, peak inflation pressure, or PIP, is now strictly separated by gestational age. We used to just start at 20 to 25 centimeters of water across the board. Not anymore. Now there's a hard division. For mature infants, 32 weeks and older, you jump right to an initial PIP of 25 to get that chest rising. But for the fragile, less compliant lungs under 32 weeks, you start strictly at 20 centimeters of water to protect them against barotrauma.
Our rhythm is evolving too. The acceptable ventilation rate is now a much broader range of 30 to 60 breaths per minute, which honestly gives you a bit more operational flexibility depending on what's happening in front of you. Plus, you get a little more breathing room, pun intended, to assess your ventilation. You now have an extended window of 15 to 30 seconds of observation to see if your initial PPV is working before you have to trigger those MRSOPA corrective maneuvers.
And finally, Section 5, Airway and Intubation Updates. Let's look at advanced airway tools. This is a real game changer. The laryngeal mask airway, or LMA, just got a major promotion. It's no longer just a backup device to keep in your pocket. The LMA is now approved as a primary rescue airway device during intense scenarios if a face mask is failing or if intubation is just unfeasible. This is huge. It empowers providers to secure an effective airway so much faster instead of repeatedly failing at a complex intubation while a baby goes downhill.
Now, when you do intubate, there's a very specific tweak to your technique. Your anatomical landmark for measuring the tube depth has shifted. You now measure to the anterior edge of the baby's upper maxillary gum, right in the midline, tip to gum. It's highly specific to keep us out of that right main stem. Also, the guidelines now officially recommend using video laryngoscopy if you have it available. Better visualization means higher first-pass success rates. Simple as that.
So when does the clock run out on the old ways? You have a hard deadline. The AAP and AHA require that all institutions transition their clinical practices and update all courses to this 9th edition content by June 1st, 2026. This isn't just a reading assignment, folks. It means updating your unit's equipment checklists, changing your EMR prompts, and retraining absolutely every member of your perinatal team. The science here is absolutely clear. Waiting at least 60 seconds to clamp a cord, holding off on oxygen until the 2-minute mark, utilizing the LMA as a primary tool, and dialing in those specific ventilation pressures. This stuff literally saves newborn lives. But paper guidelines don't save babies. Highly trained, synchronized teams do. So, with that 2026 deadline ticking closer, how are you and your team going to reprogram your muscle memory to flawlessly integrate these critical updates into your very next delivery room emergency? Thanks for hanging out with me for this explainer, and I'll catch you in the
Thank you for watching. Kindly like and subscribe and follow for more such videos.